Sarah Martinez had been walking the same hospital corridors for 12 years, her white sneakers making soft, squeaking sounds against the polished linoleum floors. At 34, she had seen more human suffering and triumph than most people witness in a lifetime. Yet somehow, she remained invisible to almost everyone around her. The Metropolitan General Hospital never slept, but it did breathe differently at night. During Sarah's shift from 11 p.m. to 7 a.m., the harsh fluorescent lights dimmed to a gentler glow, and the constant chatter of day staff gave way to the steady beeping of monitors and the occasional whispered conversation between colleagues. Sarah preferred the night shift. There was something peaceful about caring for patients while the rest of the world slept. She could take her time with each person, really listen to their concerns, and provide the kind of compassionate care that often got rushed during the chaos of day hours. On this particular Tuesday night in October, Sarah was assigned to the cardiac wing on the 4th floor. She had worked this unit countless times before, but tonight felt different somehow. Maybe it was the way the autumn wind rattled the windows, or perhaps it was the unusually high number of critical patients admitted that evening. As she began her rounds at midnight, Sarah noticed room 418 had a new patient. The chart showed James Morrison, a 62-year-old construction worker who had been admitted earlier that day with chest pains and irregular heartbeat. His family had left around 9 p.m., and now he lay alone in the darkened room, staring at the ceiling. Sarah knocked gently and entered with her medication card. "Mr. Morrison? I'm Sarah, your night nurse. How are you feeling?" James turned his head slowly, his weathered face showing both pain and worry. "Been better, miss. This ticker of mine has been acting up something fierce." Sarah checked his vitals and noticed his blood pressure was higher than it should be. More concerning was the irregular pattern she detected in his pulse. She had developed an almost supernatural ability over the years to sense when something wasn't quite right with a patient, even when the monitors showed normal readings. "Have you been having any chest pain since your family left?" she asked while adjusting his 4. "A little tightness, nothing too bad," James replied, but Sarah could see the strain in his eyes. She had learned to read the subtle signs that patients often try to hide, not wanting to be a burden or cause alarm. Sarah spent a few extra minutes with James, explaining his medications and making sure he was comfortable. As she prepared to leave, he grabbed her hand gently. "Thank you, Sarah. Nobody else has taken the time to really explain what's happening to me." This was the reality of Sarah's world. While day shift nurses juggled multiple patients and dealt with constant interruptions from doctors, visitors, and administrative demands, she could provide the kind of personal attention that made a real difference in healing. Moving to room 420, Sarah found Mrs. Chun, an elderly woman recovering from heart surgery. Her daughter had mentioned during the shift change that her mother seemed confused and restless, but the day nurse had attributed it to post-surgical disorientation. Sarah immediately noticed that Mrs. Chen's breathing seemed labored, and her color was slightly off. The monitors showed acceptable readings, but Sarah's instincts told her something was developing. She had seen this pattern before, subtle changes that preceded more serious complications. "Mrs. Chun, can you tell me how you're feeling?" Sarah asked in Mandarin, having learned basic phrases in several languages to better communicate with a diverse patient population. The elderly woman's eyes widened with surprise and relief. She began speaking rapidly in Mandarin, describing chest tightness and difficulty breathing that she hadn't been able to communicate to the day staff. Sarah immediately called Dr. Rodriguez, the attending cardiologist on call. Many nurses might have hesitated to wake a doctor over seemingly minor concerns, but Sarah had learned that her observations were usually accurate, and Dr. Rodriguez had come to trust her judgment over the years. "Doctor, I have Mrs. Chun in 420. Her vitals are stable, but she's reporting chest tightness, and I'm noticing some subtle changes in her presentation. Could you take a look?" 20 minutes later, Dr. Rodriguez arrived to examine Mrs. Chun. After a thorough assessment and some additional tests, he discovered early signs of fluid buildup around her heart, a potentially serious complication that could have become life-threatening if left undetected. "Good catch, Sarah," Dr. Rodriguez said as they adjusted Mrs. Chen's medications. "Her daughter will be relieved that we caught this early." But Sarah knew that by tomorrow morning, this incident would likely be forgotten by most people. The day shift would come in, read the updated chart, and continue with their routine. Dr. Rodriguez would make his rounds and move on to other cases. Mrs. Chun would recover, probably never knowing how close she had come to a serious setback. This was the pattern of Sarah's professional life. She prevented crises that never happened, caught problems before they became emergencies, and provided comfort during the loneliest hours of her patients' hospital stays. Yet her contributions remained largely invisible, documented only in brief notes in medical charts that few people would ever read carefully. As the night continued, Sarah moved through the cardiac wing with quiet efficiency. In room 422, she helped Mr. Williams, a heart attack survivor, work through his anxiety about returning home. His wife had been putting on a brave face during visiting hours, but he confessed to Sarah that he was terrified of having another attack when no one was around to help. Sarah sat with him for 15 minutes, explaining the warning signs to watch for and helping him understand his new medications. She gave him specific instructions about when to call 911 versus when to contact his cardiologist, and, most importantly, she listened to his fears without judgment. "The thing is," Mr. Williams said, "during the day, everyone's so busy. The doctors rush in and out, and I feel like I'm bothering the nurses if I ask too many questions. But you got time to actually talk." This was exactly what Sarah loved about night nursing, but it also highlighted a growing problem in healthcare. Hospitals were increasingly focused on efficiency and quick turnover, leaving little time for the human connection that was so crucial to healing. Night nurses like Sarah filled this gap, but their work often went unrecognized by hospital administrators who measured success primarily in terms of patient throughput and cost reduction. Around 3 a.m., Sarah was updating charts at the nurse's station when she heard the soft chime that indicated a patient was requesting assistance. The call came from room 418, James Morrison's room. When she entered, she found James sitting up in bed, clutching his chest. His face was pale and covered with a thin layer of sweat. "Sarah, something's not right. The pain is getting worse." Sarah immediately checked his monitors and saw that his heart rhythm had become more irregular. His blood pressure had dropped significantly since her last check. She recognized the signs of a potential heart attack in progress. Moving quickly but calmly, Sarah pressed the code button to alert the emergency team while simultaneously starting in 4 push of nitroglycerin. She had performed this routine many times before, but each emergency still required split-second decisions that could mean the difference between life and death. "James, I need you to stay calm," she said while preparing additional medications. "We're going to take good care of you. The cardiac team is on their way." Within minutes, the room filled with medical personnel. Dr. Rodriguez arrived first, followed by the cardiac emergency team. As they worked to stabilize James, Sarah continued monitoring his vitals and administering medications under the doctor's direction. The next hour passed in a blur of controlled urgency. James was rushed to the cardiac catheterization lab, where doctors discovered and cleared a significant blockage in one of his coronary arteries. The quick response had prevented what could have been a massive heart attack. By 5 a.m., James was back in his room, stable but exhausted. The procedure had been successful, and his prognosis was good. As Sarah checked on him, he managed a weak smile. "Thank you, Sarah," the doctor said, "if you hadn't acted so quickly." His voice trailed off, but the gratitude in his eyes said everything. Sarah squeezed his hand gently. "I'm just glad we caught it in time. You're going to be fine." As her shift neared its end, Sarah completed her final rounds and prepared her reports for the day's shift. She documented everything that had happened during the night. Mrs. Chen's early complications, Mr. Williams's anxiety counseling, and James's emergency situation. But Sarah knew that by the time the morning staff arrived, the focus would shift to new admissions, discharge planning, and the daily routine of hospital operations. Her detailed observations and quick interventions would become just another entry in the medical records. At 6:30 a.m., as the first rays of sunlight began filtering through the hospital windows, Sarah gathered her things and prepared to head home. She had prevented at least 2 potential medical crises, provided emotional support to frightened patients, and ensured that 7 people had made it safely through the night. Yet as she walked toward the elevator, passing the incoming day shift nurses, Sarah remained essentially invisible. No one would write articles about her work or give speeches about her contributions. There would be no recognition ceremonies or special awards for preventing emergencies that never fully developed. Sarah had long ago accepted this reality. She didn't become a night nurse for recognition or praise. She chose this profession because she genuinely cared about people during their most vulnerable moments. But sometimes, especially after nights like this one, she couldn't help wondering what it would be like to have her work truly seen and valued by the healthcare system she served so faithfully. As the elevator doors closed and Sarah descended toward the lobby, she had no idea that everything was about to change. Tomorrow's shift would bring events that would finally pull her out of the shadows and force the hospital and the wider medical community to confront just how much they had been taking for granted. The night nurse was about to be noticed, and when that happened, it would transform not just Sarah's life, but the way Memorial General Hospital understood the true meaning of patient care. Wednesday evening arrived with an unusual tension in the air at Metropolitan General Hospital. Sarah noticed at the moment she stepped off the elevator onto the 4th-floor cardiac unit. The day shift nurses seemed more hurried than usual, and there was an underlying current of stress that she couldn't quite identify. During the shift handoff, Nurse Patricia Williams, the day charge nurse, briefed Sarah on the patients with obvious fatigue in her voice. "It's been a rough day, Sarah. We've had 3 new admissions, and frankly, we're understaffed. Corporate has been pushing for reduced nursing hours per patient, and it's starting to show." Sarah listened carefully as Patricia went through each patient status. Room 418 now housed a new patient since James Morrison had been transferred to a regular room after his successful procedure. Mrs. Chan in room 420 was recovering well from her heart surgery complications, thanks to the early intervention from the night before. "One more thing," Patricia added, lowering her voice. Dr. Hamilton from hospital administration was asking questions about last night's incidents. Something about reviewing our emergency response protocols and nursing efficiency metrics. Sarah felt a small knot form in her stomach. Dr. Hamilton was known for his focus on cost-cutting measures and operational efficiency. If he was reviewing last night's events, it probably wasn't to praise anyone's performance. As Sarah began her rounds, she tried to push the administrative concerns from her mind and focus on her patients. But the conversation with Patricia had planted a seed of worry that she couldn't quite shake. The first few hours of her shift passed relatively quietly. Sarah spent time with each patient, checking vitals, administering medications, and providing the careful attention that had become her trademark. In room 424, she found Mr. Patterson, a new admission with heart failure who seemed overwhelmed by his diagnosis. "I don't understand all these machines and tubes," he confessed to Sarah as she explained his treatment plan. "During the day, everyone talks so fast, and I'm afraid to ask too many questions." Sarah pulled up a chair next to his bed, something she had time to do during the night shift that day nurses rarely could manage. "Let me explain everything step by step," she said patiently. "And please, ask as many questions as you need to. That's what I'm here for." For the next 20 minutes, Sarah walked Mr. Patterson through his condition, his medications, and what he could expect during his recovery. She used simple terms and drew diagrams to help him understand how heart failure affected his body and how the treatments would help. "You know," Mr. Patterson said as Sarah prepared to continue her rounds, "you're the first person who's made me feel like I'm not just bothering everyone with my questions." "Thank you." These moments reminded Sarah why she had chosen nursing, and specifically night nursing. But they also highlighted the growing problem in healthcare that Patricia had mentioned. Hospitals were increasingly focused on efficiency and rapid patient turnover, which meant less time for the kind of personalized care that truly helped people heal. Around midnight, Sarah was updating patient charts when she noticed unusual activity in the administrative offices down the hall. The lights were on, which was rare for that time of night, and she could see several people in business suits having what appeared to be an intense discussion. Her curiosity was interrupted by the call light from room 422, where Mrs. Foster, a 70-year-old woman recovering from bypass surgery, was experiencing chest pain. Sarah immediately went to assess the situation, finding Mrs. Foster anxious and reporting tightness in her chest. After checking her vitals and performing a thorough assessment, Sarah determined that Mrs. Foster was experiencing anxiety-related chest tightness rather than cardiac complications. However, given her recent surgery, protocol required that a physician evaluate any chest pain complaints. Sarah called Dr. Rodriguez, who arrived within 15 minutes to examine Mrs. Foster. After confirming Sarah's assessment, he prescribed a mild anti-anxiety medication and spent a few minutes reassuring the patient about her recovery progress. "You were right to call," Dr. Rodriguez told Sarah as they left the room. "Better to be safe, especially with post-surgical patients. Your assessment was spot on, as usual." But as Dr. Rodriguez headed back to the on-call room, Sarah noticed Dr. Hamilton emerging from the administrative offices with two other men in suits. They appeared to be conducting some sort of inspection or review, examining patient charts, and talking in hushed tones with a night supervisor. Sarah tried to continue her work normally, but she couldn't shake the feeling that something significant was happening. Her instincts, finely tuned from years of reading subtle signs in patients, were telling her that the hospital was undergoing some kind of evaluation or investigation. The answer came sooner than she expected. At 2 a.m., the night supervisor, Linda Chun, approached Sarah at the nurse's station with a serious expression on her face. "Sarah, Dr. Hamilton wants to speak with you in the conference room. He's conducting a review of nursing procedures and patient care protocols." Sarah's heart rate increased as she followed Linda down the hallway to the conference room. Inside, she found Dr. Hamilton seated at a long table with the two men in suits who introduced themselves as healthcare consultants hired by the hospital board. "Nurse Martinez, Dr. Hamilton began, consulting a thick folder of documents. "We're conducting a comprehensive review of hospital operations, with particular focus on nursing efficiency and patient care protocols. We've been examining incidents from last night and other recent events." Sarah remained silent, unsure where this conversation was heading. Dr. Hamilton continued, "According to our analysis, you've been involved in several patient situations that required additional physician consultations and emergency interventions. These incidents represent increased costs and resource utilization that we need to understand better." One of the consultants, a stern-looking man with wire-rimmed glasses, opened his laptop and pulled up what appeared to be a detailed spreadsheet. "Over the past 6 months, patients under your care have required above-average physician consultations and emergency responses. From a cost-efficiency standpoint, this pattern needs to be addressed." Sarah felt her cheeks flush with indignation. "Are you suggesting that I'm somehow responsible for patients having medical emergencies?" "We're suggesting," the other consultant replied, "that there may be inefficiencies in your approach to patient care that result in unnecessary utilization of hospital resources. Other nurses manage similar patient loads without generating as many incident reports or emergency calls." Dr. Hamilton leaned forward, his expression serious. "Sarah, we're not questioning your dedication or competence. However, we need to ensure that our nursing staff is operating in the most cost-effective manner possible. The hospital board is under pressure to reduce operating expenses while maintaining quality care standards." Sarah took a deep breath, trying to process what she was hearing. "Dr. Hamilton, the incidents you're referring to, Mrs. Chin's post-surgical complications, Mr. Morrison's heart attack prevention, These weren't unnecessary interventions. These were potentially life-saving early detections of serious medical problems. According to our analysis, the first consultant interrupted, many of these situations might have been resolved without emergency interventions if they had been managed differently. We're implementing new protocols designed to reduce what we call preventable emergency responses. Sarah stared at the three men in disbelief. They were essentially telling her that her careful attention to patients and early detection of problems was somehow a negative thing because it cost the hospital money. "What exactly are you proposing?" Sarah asked, her voice steady despite the anger building inside her. Dr. Hamilton consulted his notes again. "We're implementing new guidelines for nursing staff that will help standardize patient care and reduce unnecessary physician consultations. Nurses will be required to follow specific protocols before contacting doctors, and emergency responses will be reserved for situations that meet clearly defined criteria." The second consultant added, "We're also restructuring nursing assignments to increase efficiency. Night shift nurses will be responsible for more patients, which will require more streamlined approaches to patient care." Sarah realized with growing horror that they were essentially asking her to ignore her instincts and provide less personalized care to her patients. The very things that made her an excellent nurse, her attention to detail, her ability to detect subtle changes in patients, her willingness to spend extra time providing comfort and education, were being characterized as inefficiencies. "Dr. Hamilton," Sarah said carefully, "can you tell me what the outcome would have been if I hadn't called Dr. Rodriguez about Mrs. Chen's complications? Or if I hadn't recognized the signs of Mr. Morrison's developing heart attack?" Dr. Hamilton looked uncomfortable. "That's hypothetical, Sarah. We can't know what might have happened. What we do know is that these incidents required additional resources and increased costs." Sarah stood up slowly, her mind racing. "So you're saying that preventing a potential stroke or heart attack is less important than saving money on doctor consultations?" "We're saying," the first consultant replied coldly, "that hospitals across the country are finding ways to provide quality care while operating more efficiently. We need our staff to adapt to these new realities." Sarah looked at each of the three men, realizing that they fundamentally misunderstood what nursing actually involved. They saw her work through the lens of spreadsheets and cost analyses, reducing complex human care to simple financial calculations. "I need to get back to my patients," Sarah said finally. "Is there anything else you need from me tonight?" Dr. Hamilton nodded. "We'll be implementing the new protocols starting Monday. You'll receive training materials and guidelines this week. Thank you for your time, Sarah." As Sarah walked back to the cardiac unit, her mind was reeling. Everything she believed about patient care and nursing excellence was being challenged by administrators who had probably never spent a night caring for frightened, sick people. The rest of her shift passed in a blur of conflicted emotions. Sarah continued providing the same level of care to her patients, but she couldn't stop thinking about the conversation in the conference room. Were her colleagues also being questioned about their patient care approaches? Was the entire nursing staff being pressured to provide less attentive care in the name of cost savings? Around 5 a.m., Sarah received a text message from her friend Maria, another night nurse who worked in the intensive care unit. "Did you hear about the meeting with administration? They're reviewing all the nursing staff. Something big is happening." Sarah replied quickly, "Just finish my meeting. We need to talk." As her shift ended and Sarah prepared to leave the hospital, she realized that this was just the beginning of something much larger than a simple efficiency review. The hospital was fundamentally changing its approach to patient care, and nurses like her were caught in the middle. Walking to her car in the early morning light, Sarah made a decision that would change everything. She wasn't going to quietly accept protocols that compromised patient care. If the hospital administration wanted to reduce nursing to a series of cost-cutting measures, they were going to have to face some difficult questions about what that really meant for the people they were supposed to be serving. The night nurse was about to fight back, and when she did, it would expose problems in the healthcare system that went far beyond one hospital's budget concerns. Sarah didn't know it yet, but Her quiet rebellion was about to become a catalyst for changes that would reach far beyond the walls of Metropolitan General Hospital. For Thursday morning found Sarah Martinez sitting in her small apartment kitchen, staring at a cup of coffee that had long since grown cold. Sleep had been impossible after her confrontation with Dr. Hamilton and the hospital consultants. Their words kept echoing in her mind: unnecessary utilization of hospital resources and preventable emergency responses. Sarah had spent 12 years perfecting her skills as a night nurse, learning to read the subtle signs that other people missed, developing relationships with patients that went beyond simple medication administration. Now she was being told that her expertise was actually a problem that needed to be solved. Her phone buzzed with another text from Maria in the ICU. Emergency nursing meeting called for this afternoon. Word is spreading fast about the new protocols. Everyone's talking. Sarah realized that whatever was happening at Metropolitan General was affecting the entire nursing staff, not just her. She made a decision that would have seemed unthinkable just 24 hours earlier. She was going to document everything and fight back. Opening her laptop, Sarah began writing a detailed account of her meeting with administration, including the specific language they had used about cost reduction and efficiency measures. She also began compiling a list of patient cases from the past 6 months where her interventions had prevented serious complications or saved lives. The case of Mrs. Chun stood out particularly clearly. Sarah had detected early signs of post-surgical complications that could have led to cardiac tamponade, a life-threatening condition where fluid accumulates around the heart. If she had followed the new protocols and waited for more obvious symptoms before calling a doctor, Mrs. Chun might have died. Similarly, James Morrison's developing heart attack had been caught early because Sarah recognized subtle changes in his condition. Under the proposed new guidelines, she would have been required to wait for more severe symptoms before contacting a physician, potentially resulting in massive heart muscle damage or death. Sarah spent the morning documenting case after case where her inefficient approach to nursing had actually saved lives and prevented costly emergency situations. The irony was clear. The hospital was trying to reduce costs by implementing protocols that would likely result in more emergencies, longer hospital stays, and potentially preventable deaths. By noon, Sarah had compiled a 15-page document detailing the contradiction between quality patient care and the new efficiency measures. But she knew that submitting this to Dr. Hamilton would likely result in disciplinary action or termination. She needed a different approach. Sarah remembered Dr. Rodriguez's consistent support for her clinical judgment over the years. She decided to reach out to him before the afternoon nursing meeting to get a physician's perspective on the new protocols. When she called Dr. Rodriguez, his response was immediate and forceful. "Sarah, I've been hearing rumors about new nursing protocols, but I had no idea they were targeting experienced nurses like you. Your clinical observations have been invaluable over the years. I've lost count of how many times your early interventions have prevented serious complications." Dr. Rodriguez paused before continuing. "I think there's something you should know. I've been noticing increased pressure from administration to reduce physician consultations and emergency responses. Several of us have been questioned about our decision-making regarding patient care. This isn't just about nursing. They're trying to reduce costs across all departments." This revelation gave Sarah a new perspective on the situation. The hospital wasn't just targeting nurses. They were implementing system-wide changes that prioritize financial considerations over patient care. This was bigger than she had initially realized. "Dr. Rodriguez, would you be willing to review my documentation of patient cases and provide a medical opinion about the outcomes if different protocols have been followed?" "Absolutely," he replied without hesitation. "And, Sarah, I think you should know that several physicians are very concerned about these changes. We've been discussing the situation, and there may be more support for your position than you realize." That afternoon, Sarah attended the emergency nursing meeting in the hospital's main conference room. The tension in the air was palpable as nearly 50 nurses from all shifts and departments gathered to hear about the new protocols. Dr. Hamilton stood at the front of the room with the same two consultants from the previous night. His presentation was filled with corporate buzzwords and efficiency statistics, but Sarah noticed that he carefully avoided discussing specific patient outcomes or clinical scenarios. These new guidelines will help standardize our approach to patient care, Dr. Hamilton explained, ensuring that all nurses follow evidence-based protocols that optimize resource utilization while maintaining quality standards. One of the consultants pulled up a PowerPoint slide showing cost savings projections. Implementation of these protocols at similar hospitals has resulted in average cost reductions of 12 to 15% in nursing-related expenses. Sarah listened as her colleagues asked increasingly pointed questions about how the new protocols would affect patient care. The answers from administration were uniformly evasive, focusing on efficiency metrics rather than clinical outcomes. When the formal presentation ended, Dr. Hamilton opened the floor for questions. Sarah stood up, her heart pounding but her voice steady. Dr. Hamilton, can you explain how these protocols would have affected specific patient outcomes? For example, what would have happened to Mrs. Chun in room 420 if I had waited for more severe symptoms before calling Dr. Rodriguez about her post-surgical complications? Dr. Hamilton looked uncomfortable. Nurse Martinez, we can't engage in hypothetical discussions about specific cases. These protocols are based on best practices from across the healthcare industry. Sarah pressed on. But these aren't hypothetical cases. These are real patients who received life-saving interventions because nurses were allowed to use their clinical judgment and experience. How do you reconcile cost savings with potentially preventable deaths? The room fell silent. Sarah's colleagues were watching the exchange with intense interest, and she could see nods of agreement throughout the audience. One of the consultants stepped forward. Nurse Martinez, your concerns are noted, but you need to understand that healthcare is changing. Hospitals can no longer afford to operate the way they did 20 years ago. These protocols represent industry standards for efficient care delivery. Maria from the ICU stood up next. I'd like to know what qualifications these consultants have for determining nursing protocols. Have either of you ever actually worked as a nurse or cared for patients? The question hit its mark. Neither consultant had clinical experience, and their discomfort was obvious to everyone in the room. Over the next 30 minutes, the meeting became increasingly tense as nurses throughout the hospital shared similar stories of administrative pressure to reduce patient interactions and limit physician consultations. A clear picture emerged of system-wide changes that prioritize cost reduction over quality care. Dr. Hamilton finally ended the meeting by announcing that the new protocols would be implemented on Monday as scheduled, regardless of staff concerns. These changes are necessary for the hospital's financial viability, he stated firmly. Anyone unable or unwilling to follow the new guidelines will need to consider whether this is the right workplace for them. After the meeting, Sarah found herself surrounded by colleagues who wanted to discuss the situation further. The conversation moved to the hospital cafeteria, where nearly 20 nurses continued sharing their experiences and concerns. This isn't just about our jobs, said Janet from Pediatrics. This is about patient safety. If we can't use our clinical judgment to advocate for our patients, who will? Maria nodded in agreement. I've been nursing for 18 years, and I've never seen anything like this. They're essentially asking us to ignore our professional training and experience. As the group talked, Sarah realized that they had more power than any of them had initially understood. Nurses were the backbone of hospital operations, and if they acted together, they could force administration to reconsider these dangerous protocols. What if we documented everything? Sarah suggested. Every case where the new protocols would have resulted in worse outcomes. Every instance where administrative pressure conflicts with patient safety. If we present a unified response with solid clinical evidence, it would be harder for them to dismiss our concerns. The group agreed to work together over the weekend to compile comprehensive documentation of patient cases and clinical scenarios. They also decided to reach out to sympathetic physicians who might support their position. Dr. Rodriguez was the first physician to respond when Sarah contacted him later that evening. "Sarah, I've been talking to my colleagues about this situation. We're all concerned about the implications of these new protocols. Would you be interested in presenting your documentation to a group of attending physicians?" By Friday afternoon, Sarah had organized a presentation that would take place Sunday evening, just hours before the new protocols were scheduled to be implemented. She had compiled dozens of patient cases, consulted with experienced nurses throughout the hospital, and prepared a comprehensive analysis of how the proposed changes would affect patient outcomes. But Sarah knew that documentation alone wouldn't be enough. The hospital administration had already made it clear that they were more concerned with financial metrics than clinical arguments. She needed something that would force them to pay attention to the broader implications of their decisions. The answer came from an unexpected source. James Morrison, the patient whose heart attack Sarah had helped prevent earlier in the week, had been discharged on Friday morning. Before leaving, he had asked to speak with Sarah personally to thank her for her care. "That young lady saved my life," James told his daughter as they prepared to leave the hospital. "If she hadn't caught the warning signs when she did, the doctors said I could have died." James's daughter, it turned out, was a reporter for the local newspaper who specialized in healthcare issues. When she heard her father's story and learned about the new protocols being implemented at Metropolitan General, she became very interested in investigating further. "Dad, do you think this nurse would be willing to talk to me about what's happening at the hospital? This sounds like a story that people need to hear." Sarah spent Saturday afternoon being interviewed by Lisa Morrison, James's daughter. The conversation covered not just the specific incident with her father, but the broader pattern of administrative pressure to reduce patient care in the name of cost savings. "What you're describing isn't unique to your hospital," Lisa told Sarah. "I've been investigating similar situations at hospitals across the state. There seems to be a trend toward prioritizing financial efficiency over patient safety, but most nurses are afraid to speak out because they fear losing their jobs." Lisa explained that she had been working on a series of articles about healthcare cost-cutting measures and their impact on patient outcomes. Sarah's story, combined with the documentation she had compiled, could provide the concrete evidence needed to expose these dangerous practices. "Are you willing to go public with this information?" Lisa asked. "I can protect your identity initially, but if this story gains traction, you might need to be prepared for some intense scrutiny." Sarah thought about Mrs. Chun, James Morrison, Mr. Patterson, and all the other patients whose lives had been saved or improved by the kind of careful, attentive nursing that the hospital was now trying to eliminate. The choice was clear. "Yes," Sarah replied. "People need to know what's happening. If administrators are going to prioritize profits over patients, then the public has a right to know about it." Sunday evening's meeting between nurses and sympathetic physicians confirmed what Sarah had suspected. The medical staff was just as concerned about the new protocols as the nursing staff, but they had been reluctant to speak out against hospital administration. Dr. Rodriguez addressed the group of nearly 30 healthcare professionals. "What we're facing here isn't just a policy change. It's a fundamental shift away from patient-centered care toward profit-centered care. As medical professionals, we have an ethical obligation to speak out when patient safety is compromised." The group agreed to present a unified response to hospital administration, demanding a delay in protocol implementation pending a thorough review of patient safety implications. They also agreed to support Sarah if she decided to go public with her story. Monday morning arrived with unprecedented tension at Metropolitan General Hospital. The new protocols were scheduled to be implemented, but word had leaked about the nursing and physician resistance. Dr. Hamilton arrived early to find a formal petition signed by over 60 healthcare professionals demanding a review of the policy changes. At the same time, Lisa Morrison's article was published in the morning edition of the city newspaper. The headline read, "Local Hospital Implements Cost-Cutting Measures That May Compromise Patient Safety." The article featured detailed examples of how the new protocols could have resulted in preventable deaths, along with quotes from anonymous healthcare professionals describing the pressure to prioritize financial concerns over patient care. The article created an immediate public reaction. The hospital's phone lines were flooded with calls from concerned community members, and local television stations began requesting interviews with hospital administrators. Dr. Hamilton called an emergency meeting with the hospital board of directors for that afternoon. The board, suddenly facing negative publicity and potential liability issues, demanded a full explanation of the new protocols and their implications for patient safety. Sarah was at home when she received a call from Dr. Hamilton's office requesting that she attend the board meeting to answer questions about her patient care practices. She knew this could be the moment that ended her career, but she also knew it might be her only chance to directly address the people making these decisions. The board meeting took place in a large conference room filled with hospital administrators, board members, and several attending physicians who had requested permission to attend. Sarah entered the room wearing her best professional attire, carrying a folder containing all of her documentation. Board Chairman Robert Chin opened the meeting by acknowledging the morning's newspaper article and its potential impact on the hospital's reputation. We need to understand exactly what's happening here and whether there are legitimate patient safety concerns that need to be addressed. Dr. Hamilton began by defending the new protocols, emphasizing their cost-saving potential and their successful implementation at other hospitals. He characterized the nursing resistance as an unwillingness to adapt to modern healthcare realities. When Sarah was invited to speak, she stood up and looked directly at each board member before beginning. Ladies and gentlemen, I became a nurse because I wanted to help people during the most vulnerable moments of their lives. For 12 years, I've worked the night shift in this hospital, providing care when most of the world is asleep. Sarah opened her folder and pulled out photographs of several patients, including James Morrison and Mrs. Chun. These are people whose lives were saved because I was allowed to use my clinical judgment and experience to detect problems before they became crises. Under the new protocols you're implementing, these people might have died. For the next 20 minutes, Sarah walked the board through specific case studies, explaining in clear, non-medical terms how the proposed changes would have affected each outcome. She described the subtle signs that experienced nurses learn to recognize, and how the new protocols would prevent nurses from acting on these observations. The consultants you hired, Sarah continued, characterized my patient care as inefficient because it resulted in additional physician consultations and emergency responses. But those consultations and responses prevented heart attacks, strokes, and other life-threatening complications. Is saving money worth risking lives? Dr. Rodriguez spoke next, providing medical confirmation of Sarah's clinical assessments and explaining how nurse-physician collaboration was essential for optimal patient outcomes. Several other physicians echoed his concerns about the impact of reduced nursing autonomy on patient safety. Board member Patricia Williams, a retired nurse herself, asked pointed questions about the consultant qualifications and the evidence base for their recommendations. It became clear that the new protocols were based primarily on financial modeling rather than clinical research or patient outcome data. The meeting continued for over 2 hours, with board members asking increasingly detailed questions about specific aspects of the new protocols. Sarah could see that her presentation was having an impact, but she wasn't sure whether it would be enough to change the outcome. Finally, Board Chairman Chin called for a private discussion among board members. Sarah and the other healthcare professionals were asked to wait in an adjacent conference room while the board deliberated. 30 minutes later, they were called back to hear the board's decision. Chairman Chun stood up to address the group, his expression serious but not hostile. After hearing today's presentations and reviewing the potential implications for patient safety, the board has decided to postpone implementation of the new nursing protocols pending a comprehensive review by a committee that will include both clinical and administrative perspectives. Sarah felt a wave of relief wash over her, but Chin wasn't finished speaking. Furthermore, he continued, the board recognizes that we may have been overly focused on cost reduction without adequately considering the clinical implications of our decisions. We're committed to finding ways to improve efficiency that don't compromise the quality of care that has made this hospital a trusted part of our community." Dr. Hamilton's expression was grim, but he nodded in acceptance of the board's decision. The consultants gathered their materials without comment, clearly understanding that their recommendations had been rejected. As the meeting concluded, several board members approached Sarah personally to thank her for her courage in speaking out. "You reminded us of why this hospital exists," Patricia Williams told her. "We never should have lost sight of that." The following weeks brought significant changes to Metropolitan General Hospital. The nursing protocols were completely rewritten with input from clinical staff, and the hospital implemented new policies ensuring that patient care decisions would always involve healthcare professionals with direct patient experience. Dr. Hamilton quietly resigned his position and was replaced by a new administrator with a nursing background who understood the importance of supporting frontline healthcare workers. Sarah returned to her night shift duties, but her role at the hospital had fundamentally changed. She was invited to join multiple committees focused on patient care improvement and nurse retention. Her voice, once invisible in the darkness of the night shift, had become a powerful advocate for nursing excellence throughout the hospital. The newspaper article about the protocol controversy was picked up by other media outlets, sparking a broader conversation about healthcare cost-cutting measures and their impact on patient safety. Sarah was invited to speak at nursing conferences and healthcare policy forums, share her experience, and advocating for policies that supported rather than undermined nursing expertise. James Morrison made a full recovery and returned to work 3 months later. He often told people about the night nurse who saved his life and how her attention to detail had made all the difference. Mrs. Chin sent Sarah a card every year on the anniversary of her surgery, thanking her for the care that had prevented serious complications. 1 year after the protocol controversy, Sarah was promoted to night shift supervisor, a position that allowed her to mentor other nurses and ensure that the lessons learned from her experience were passed on to the next generation of healthcare professionals. On quiet nights, when Sarah walked the same hospital corridors she had traveled for 13 years, she reflected on how much had changed. The night shift was no longer an invisible part of hospital operations. Nurses were encouraged to use their clinical judgment and were supported when they advocated for their patients. Sarah had learned that being noticed wasn't just about recognition or praise. It was about having the power to advocate effectively for the people who needed her voice. The night nurse was no longer invisible, and that visibility had created ripple effects that improved patient care throughout the hospital and beyond. The transformation hadn't been easy, and there were still challenges in healthcare that needed to be addressed. But Sarah had proven that one person, armed with conviction and supported by colleagues who shared her values, could make a difference that extended far beyond the walls of a single hospital. Most importantly, Sarah continued to do what she had always done best: provide excellent patient care during the hours when most people slept, ensuring that vulnerable patients received the attention and advocacy they deserved. The only difference was that now, her work was valued and supported by an institution that had finally learned to see the true meaning of healthcare excellence.